on to our next speaker, Dr. SAJJAD, and he has again something different to show us. And Dr. SAJJAD is again a professor from SKMS Medical College, Bhimina, Srinagar. And we look forward to watching your video, Doctor.
Good afternoon. Thanks for getting me as a speaker. Basically, I am sharing a case which was as phacomorphic hypermature cataract with very shallow AC. So I initially thought I'll just go ahead with the this envelope technique without disturbing much things, and maybe I have to extend incision for the going simply through SICS, not the phaco. But to the luck, the edges got inverted on either side of these envelope part of. So after that, then I decided just to release the margins with the this 1R scissors, and then complete the rexes with the microforceps. So this was how I found that the rexes is not running away, and I may be comfortable to complete the rexes rightly without extending, and maybe I'll go ahead with normal phaco. So the rexes I completed later with the help of the capsulotomy needle, and the edges I couldn't just get it through it. After this, I decided now to go with the phaco. So the rexes is quite good to maintain the emulsification procedure. So that is how I did the direct chop, completed packing and taking all the bits of the nucleus very comfortably. Without any hassles. These are some of the last pieces. Then putting normally and closure of the ports. So that was a very comfortable end of it. Thank you very much.
Thank you very much, Doctor. The questions are, now in a phacomorphic glaucoma, I'm sure we would all ensure that we give mannitol or oral glycerol to soften the eye. But in a phacomorphic glaucoma with an intumescent cataract, would any of us consider being prepared for a limited vitrectomy along with it? Or do we go for a small central opening and decompressing the bag and go about it in a standard way after with the pre-op measures alone? Gaurav? Gaurav, unmute yourself.
Am I audible?
Yeah.
Yeah. So I'm not a fan of blind vitrectomy. I mean, if I can't see, I've seen it being done by some like big people, Dr. David Chang and few others, but somehow I don't think it's a great thing. So I would be more in tune of like, giving measures like giving mannitol and Dimox to the patient beforehand, and then preparing well for the surgery with all the measures like, using good viscoelastic, soft shell technique, hydro, kind of decompressing the lens with a side port. I mean, going through a paracentesis, all those things which have been described, starting with a small rexis and enlarging it, all those things that can be done. I would definitely do all that. And I would maybe not, do a primary vitrectomy just to, I would also look at the lens thickness, I mean, if possible. And also I would look at the AC depth. They are big predictors of also the, how the anterior curvature of the lens is. And so even sometimes doing an OCT of the anterior capsular area, it shows you pockets which can be seen. Dr. Dhami's team, their group has described that, and you can see on the slit lamp also. So, but phacomorphic definitely requires special attention. Yes.
Yes, Dr. Rohit?
I think Dr. Gaurav has mostly all the things.
Yes.
So I would do a closed chamber cortical decompression.
Yes.
Yeah, and then create a small rexes, do the cortical debulking from the periphery, because when you're trying to enlarge the rexes, because in the mid periphery, the cortex has not been taken care of when you're doing cortical decompression. So that would also be taken care of. Vitrectomy, definitely, I would definitely not go and venture into that by any means. Mannitol and everything, as Dr. Gaurav has perfectly said.
And also remember that the rexis needs to be enlarged at the end of the procedure. But when it comes to doing a decompression, would you use your syringe, or would you use your IA, or would you even go ahead and use your phaco probe?
No, Doctor.
No, I'm just putting all the things on.
Yeah, Dr. Mohan is a great fan of doing that punch, that phaco punch. It has not caught my fancy.
Yeah.
So I use to the syringe with a 30 gauge needle.
Yes.
I use a 30 gauge needle.
Yes.
Yeah.
Yes.
And we should have a syringe which is 2 ml or 1 ml, not a 5 ml syringe, because it will set up a very strong aspiration, and also go from a fresh paracentesis port with good viscoelastic, filling the chamber, so that, and we should not forget femto assisted rexis if the option is available. That's a big saver as well.
And what would be the viscoelastic which you would use? Would you want to use only cohesive, or would you want to do both cohesive and dispersive, or would you feel that dispersive will do?
Usually one should use a viscocohesive because you want to, flatten the anterior capsule. But if you're using it, if you're doing with a closed chamber and with the fresh paracentesis, because at times with the majority of the audience, they would not be handy with the, a viscocohesive for that matter. A viscodispersive with a guided, as Dr. Gaurav has said, don't use a 5 ml. I use a 1 ml, 1 cc syringe to just aspirate.
Okay.
I would like to give a slightly different view on this anterior vitrectomy. I think it's really a lifesaver in certain extreme situations. Obviously, all the preoperative measures that was mentioned by both of them regarding use of IV mannitol, even giving a periocular injection and then giving nice massage, all those things can be tried. But sometimes in spite of all these measures, the intraocular pressure doesn't come down, or as soon as you make your first incision, there's a lot of upthrust. In these cases, even though obviously in extremely small eyes, it might be difficult to even identify where the pars plica ends and where the pars plana starts. But in normal eyes, you can go at 3 to 3.5 millimeters. I have done it on a few occasions. Just putting in a trocar itself with the surge of fluid that comes out, or just going in with a vitrectomy probe and just removing about 0.1 cc to 0.2 cc. I don't even introduce a irrigation cannula inside. Does immediately you find that things come under control. The lens iris diaphragm goes back and things are more under control. It's not that I've done this frequently, but there have been a few occasions when I had to do it either preoperatively or intraoperatively when I find that the upthrust is quite unmanageable. Intraoperatively, I am a little more wary of doing that, because if it's a suprachoroidal hemorrhage that's causing it, this could end up in a fairly difficult situation. But preoperatively, doing it as a first step, and even before you opening up the anterior chamber, making an incision of 3 to 3.5 millimeters, going with a vitrectomy cutter and just doing a very limited anterior vitrectomy sometimes does make things come under better control.
I wouldn't be too sure. Like Gaurav, I still believe it's a blind procedure, and there is a challenge. And the anatomy of the eye is, of course, you said in normal eyes, you could consider an anatomy of a small eye is a very big challenge. But I think we need a retina person amongst us to really put it right with full clarity. So yes, we should be conscious about the challenges of doing it. So I wouldn't want the audience to go back with the message. Maybe they could, initial cases, they could have a retina colleague doing it for them if they are caught in a situation when they feel the entire surgery is going to become very